everyone. Good afternoon. Thank you for joining us. I'm Dr. Mary Ambach. This is our first Facebook Live event, so we're pretty excited. We are introducing this segment that's called Ask the Docs series. And it is a 30-minute question and answer session where Dr. Rogers and I, Dr. Ambach, are making ourselves available to our public viewing audience to ask us questions about specific topics. And these topics are on regenerative medicine and innovative treatments for orthopedic conditions. So without further delay, I'm going to introduce Dr. Christopher Rogers.
Hello, I'm Chris Rogers. Thank you for joining us today. I'm super excited to be here. Dr. Ambach and I love this new science, and we're excited to share it with you. We've treated patients with non-surgical treatments for spine injuries and joint pain for many years. And this new science is allowing us to offer new treatments not previously available. We are very interested in sharing with you the evidence, the scientific evidence that supports the use of these treatments that are based on using your own cells to heal different injuries. This is an evolving science, so we will have updates every month as the science evolves. We want to bring you the latest and greatest in this field called regenerative medicine, which is based on the premise that your body can heal itself, and we're figuring out how to augment that healing so that previously untreatable conditions can now be treated. So Dr. Ambach is going to lead us with some questions from the audience. If you can just tell us how our audience can enter their questions, and then we'll be happy to answer those for you.
Okay, so this is our first session, and every session we have a specific topic to discuss. So our topic for today is non-surgical treatment for osteoarthritis using PRP or platelet-rich plasma and cell-based therapies. So I know many of you are still signing on, logging on, trickling in. So go ahead and put your questions in the comment section, or you can message us, and then we can go ahead and answer those questions as they come in. We're going to go ahead with some questions as well that a lot of our patients ask us. These are most commonly asked questions regarding this topic. So while we're waiting for more questions to trickle in, we're going to go ahead and tackle these most commonly asked questions. So first question, what is PRP? What is platelet-rich plasma? I know many of you probably know what it is, but for those that don't, we're going to explain that to you. Dr. Rogers?
Yes, so platelet-rich plasma is a treatment that has been around since 1980s when Dr. Ferrari first used cells from the blood to heal wounds after patients were recovering from surgery. And since then, in the early 2000s, it became obvious that these same cells, these platelet cells, which are found in your blood, can be helpful for treating various orthopedic conditions, specifically osteoarthritis and tendon and ligament injuries. And this is huge for our field because previously we were just managing the symptoms of osteoarthritis. Osteoarthritis, of course, is a condition where the cartilage will degenerate and thin. This causes bruising and pain in the bones of the joint. There can be looseness of the joint with the ligaments stretching out or being torn. And then eventually this leads to inflammation and pain and swelling. And so, in the past 40, 50 years, we've had cortisone injections, we've had physical therapy, we've had bracing. And then when the arthritis became too severe, a joint replacement was typically the solution. Well, there are a lot of people who aren't ready for surgery. There are a lot of people who are not getting better with that traditional conservative care. And so along comes platelet-rich plasma, which is shown to be very helpful for osteoarthritis. Numerous studies published now showing placebo-controlled trials showing the effectiveness and the safety of using your own cells. So what is it? Platelet-rich plasma. Basically, platelets are these little cells in your blood that release growth factors that stimulate cells to grow and multiply and also suppress inflammation and heal tissue. Platelets, you make about 10 million of these a second. It's quite remarkable that our body is just constantly making these platelets. They only live about 7 days and then they're gone. Your body's continually making new ones. So if someone says, how old are you? You just say, well, what cell do you want me to talk about? I'm 7 days old if you're asking my platelets. And those platelet cells can be concentrated by using a centrifuge. You see behind me some centrifuges that we use. We also process in this sterile hood where we can make these biologic treatments that can be administered to joint arthritis, tendon injuries, ligament injuries to stimulate healing, decrease inflammation.
Thank you, Dr. Rogers. Patients always ask us, how do we make PRP? So this is a simple blood draw. It's kind of like when you go to a lab test and get a blood test done. It's done in the clinic, and we get about 5 tablespoons of your blood, anywhere from 30 to 60 cc of your blood, and we centrifuge it in the machine, just like Dr. Rogers has told us. So I'm really excited. There's a lot of questions that are trickling in. So the first question that we have here, can you discuss osteoarthritis of functional hallux limitus with comorbid plantar fasciosis? So it's this small.
We'll start off with a very specific one. That's good.
Very specific, yeah.
Yeah, so Hallux rigidus or Hallux limitus. Hallux refers to the big toe. So what can happen is the cartilage in the joint can degenerate. The joint can become stiff. It can make it very painful to walk, and this can be associated with other conditions in the foot. The other structure you mentioned there called the plantar fascia, which is a sheet of tissue that connects your heel bone to your toes, which creates this nice support of the arch of the foot. Those tissues can become degenerated and torn. When that happens, we call it fasciosis. We used to call it plantar fasciitis. Now we call it plantar fasciosis, which means those tissues are degenerated, they're swollen, they're irritated, and they hurt. PRP has been used successfully in our clinic as well as in published clinical trials showing effectiveness and safety when these platelets are injected directly into that degenerated fascia to decrease heel pain, decrease foot pain. For Hallux limitus or Hallux rigidus, that's a more degenerative type condition. If the joint is completely fused and stiff, the best we can hope is to decrease some pain and inflammation. We're probably not going to restore the motion to that joint, but if you capture it early enough, we can probably slow the progression, although I'm speaking from opinion. And one thing I'd like to say is there will be times where we're speaking from our experience with patients, or we're speaking with our knowledge of the basic biology of these treatments. And then there are clinical trials where a group of patients have actually been studied under clinical trial, and that's been compared to a placebo-controlled patient group. So we want you to understand the difference between our experience, the published literature. There are similarities. There are cases where we can be very specific. So for example, in plantar fasciosis, we have both experience, there's published literature. Hallux rigidus, we have experience, but there's not a lot of published literature yet.
Yes, so since our topic is in osteoarthritis, in case you are wondering how platelet-rich plasma helps heal osteoarthritis, Dr. Rogers has kind of alluded as to some of the mechanics on how this happens. But platelet-rich plasma acts like a long-acting cortisone. It acts like an anti-inflammatory. So it helps decrease the inflammation of your joint, and it helps with the pain. So there's a question here with regards to when do we expect the pain relief. That can happen typically about a month is the earliest. Most of the time it could take about 3 to 4 months, but as early as 1 month you can see the relief. So another way that platelet-rich plasma also helps with your arthritis is it does create this environment in your joint wherein it makes it really conducive for your joint to heal. That makes it more possible to slow down the degeneration or slow down the arthritis in your joint. And it can even improve the arthritis in your joint. So there has been imaging studies of before and after MRIs or before and other MRIs with special dye that they have shown on patients that have received these cell-based treatments that actually showed some improvement. All right. Before we go to our next question, for those of you who are just joining in, welcome to our Ask the Docs series. This is our first session, and our topic for today is non-surgical treatments of osteoarthritis using platelet-rich plasma and cell-based therapies. And this is a 30-minute question and answer session wherein we are making ourselves available to answer questions from the public regarding this topic. So go ahead and write your questions in the comments, or you can message us and we'll answer those as they come along. So next question, Dr. Rogers, does PRP help regenerate tendons, ligaments, cartilage, or bone?
Yes, so as you might imagine, those tissues are all very different and unique. And interestingly, tendons behave differently in different parts of the body. So we have good evidence that injecting platelets into the tendon of, say, for example, golfer's elbow or tennis elbow, which is a tendon that can become degenerated or torn in the elbow. Very good published data showing both safety and efficacy of this treatment. Some studies have even compared it to the results of surgery, showing as good as or superior results long-term using these non-surgical treatments. In the case of tennis elbow, it's also been demonstrated in tendons in the knee. So for example, something called jumper's knee, where you have a patellar tendon injury. There's some data on Achilles tendon, very limited data in the rotator cuff tendon in the shoulder. So we're learning that each tendon has its own unique personality. It might like different types of PRP. In the office here in the lab, we actually make a couple of different kinds of PRP, where, for example, one may have a very high platelet count, one may have a medium platelet count, one may have a very high white blood cell count, one may have no white blood cells whatsoever. So we're really customizing these treatments to the tendon that we're treating, as well as the nature of the injury and the degree of the injury. That's also very important. So a very small tear will respond and need different treatment than a very large tear, for example. For osteoarthritis, osteoarthritis is a very complicated disease. It's a chronic inflammation in the joint. That means your immune cells are secreting molecules that slowly degrade the cartilage. The cartilage will soften and thin. This then causes stress to the bone, which also then can cause inflammation in the joint. Platelets have been shown to release growth factors that make the cartilage more healthy. They help prevent the cartilage cells from dying prematurely. They decrease the overactive immune system in the joint. So much like a cortisone shot it would decrease the inflammation in the joint. Very complicated mechanisms, many different kinds of cellular mechanisms going on there with PRP in the joint.
Thank you, Dr. Rogers. I have a question here. I have severe spinal canal stenosis at L4-L5 due to disc extrusion and moderate at L3-L4. They recommend surgery, but I don't have any back pain. Can you help with this? So I always tell my patients, and Dr. Rogers will probably agree with this, we treat the patient, but we don't treat the MRI, or we don't treat the imaging study. So in your case, if you do have a big disc extrusion, or a disc herniation, first of all, you're going to come into the clinic, we're going to examine you, and we're going to see what your physical exam looks like. We want to make sure that your nerves are functioning. We want to make sure that you are able to do your activities of daily living. And we want to see also what your level of activity is and what your goals are. So we have patients that come in and say, you know, I want to get this treated because I want to go back to play tennis. So depending on what our goals are, then we go ahead and plan for the treatment. So with regards to your case, if your spinal stenosis does not cause any radicular symptoms, if it doesn't cause any leg weakness.
It means sciatica, radicular pain. Correct. For those who don't know, that means sciatica.
Or if it doesn't cause any loss of bowel or bladder function, we don't have to be aggressive in going for injections for these cases. Most of the time, we just need re-strengthening of your trunk, of your spine support, so that you can provide support for your spine. And again, you know, it's something that we just need to follow over time. there's a lot. If you get an MRI of 100 people walking the street with no symptoms, probably 90% of them or more will have spinal stenosis or will have abnormal findings in their MRI, and it doesn't necessarily mean that we treat it just because the MRI was abnormal.
Yeah, that's exactly right. It's a good point that we don't treat the MRI. If the MRI shows a herniated disc, it doesn't mean that that's necessarily the cause of the pain. However, if after examining you, we do determine that the herniated disc is pinching a nerve, there are treatments that we can offer. Typically in the past, we would do something what's called an epidural steroid injection if that patient could not get relieved with more conservative measures such as physical therapy. And epidural steroid injections can be helpful. That's where we inject steroids around the nerve in the spine. Here in the office under X-ray guidance, and that's something that I've been doing since 1993 actually, and it's actually the most common procedure in the United States. 11 million epidural steroid injections done in the United States every year. However, that typically does not provide long-lasting benefit for many patients, and so what we're finding is that platelet-rich plasma or other cell-based therapies can serve as a substitute to steroid, and they last longer. They may also contribute to healing of that herniated disc. There's some good studies that show that if you culture those disc cells in a petri dish with PRP, those cells thrive, they grow, and we think that that contributes to disc healing. There's many different ways that these cells can be applied to that specific condition. I will tell you, if you have severe stenosis where the nerves are severely compressed, you do have sciatica, you do have numbness or weakness in the legs, those patients are, many of them are more likely going to go on to need a surgical procedure to decompress those nerves. But we do have anecdotal experience with patients who've had moderate, in rare cases, severe stenosis who have benefited with long-term relief from these therapies. So I always tell folks I've treated tens of thousands of patients with spine pain. I've never seen two patients exactly the same. I've never seen two lumbar spine MRIs exactly the same. We really need to sit down with you, spend 45 minutes or more evaluating the situation and determining what's going to be most effective for you.
Okay. Next question. Does these treatments help with severe osteoarthritis?
Yeah, they do. And severe osteoarthritis can be defined by one of three ways. Either you're really suffering, your knee is severe to you, and you have severe pain and you can't do the things you want to do. That's one definition of severe. Another definition would be your X-ray looks really terrible. I will tell you, X-ray is a horrible predictor of pain. As an example, if you had a cortisone shot today and you have no pain tomorrow, your X-ray still looks horrible. So the X-ray is really a poor predictor of pain. MRI might be a little bit better predictor of pain, and we may look at your MRI and say, wow, you have severe arthritis. Regardless of the definition, if we decide that you have severe osteoarthritis, we have treated many patients using not PRP necessarily, which does work for some patients with severe arthritis, but we usually use PRP for mild to moderate arthritis. But for those severe cases, we found that we get better results if we use some kind of cell-based therapy, either from bone marrow cells or from cells from the fat. And just to give you an idea, I'm about ready to publish a paper with 192 patients, average age 70 years old, who were all trying to avoid knee replacement surgery because of their severe arthritis on the basis of X-ray and MRI. And this study actually was performed with 3 other physicians, 1 in Italy and 2 on the East Coast here in the States. And we all did the same procedure. We took cells from the fat and we injected those cells into the knee joint. And 3 years later, we find that 92% of those patients were able to improve enough to avoid knee surgery. So this is a game changer for the field of orthopedics. And just realize that every month, this technique continues to improve. But this technique that we have right now is pretty good. 92% is a great place to start. We're trying to drive that up to 99% if possible. As the science, evolves, we're going to, I think, achieve that. I think I can boldly say here that 5 years from now, I think it's going to be standard of care to offer cell therapy first. Only the patients that fail that therapy will go on to need a joint replacement surgery. I mean, the obvious cases where, sorry to interrupt, the obvious case where surgery probably is indicated is where on the MRI there's massive damage to the bone. We call it bone marrow edema. Or if there's significant malalignment of the joint. You know, you see these folks that are bow-legged or knock-kneed. Those are harder to treat with cell therapy. But the other folks, like I said, 92% of them do very well, and we're following them for 3 years. I've actually been doing this for more than 5 years with this particular protocol, showing really great results.
Perfect. So for those of you that are just joining in, again, welcome to our first Facebook Live event. And this is Ask the Docs series. And we are answering questions from our audience with regards to any questions that you have regarding the topic. And the topic for today is non-surgical treatments of osteoarthritis using PRP and cell-based therapy. So we have about 10 minutes more, so we can go over. We've got 3 more questions here. So one question is, if we were to seek treatment and we live in Texas, how many appointments would that require? So this is very variable depending on your condition and depending on what we are treating. So you're going to have that consultation first. That way we can identify the source of your pain, what we need to treat, and have a game plan and have a treatment plan for you. Most of these injections work really well with just one injection. So you may need to come back for that injection, or we can do the clinic evaluation and the injection in the same day as well.
May I just interrupt you for 1 second? I would just add, in this time with the current situation with traveling being difficult for people, Dr. Ambach and I have spent the last 10 years or more traveling around the country and around the world lecturing at medical conferences. And so we've made a lot of friends. And I'm sure we have a friend, a physician who lives near you. So we're more than happy to refer you to colleagues that we trust and that we know are doing similar high quality work that we're doing here in San Diego. So more than happy to refer you to our network of friends around the world.
That's great. Dr. Rogers, thank you for that. Before we go on to the next question and before we answer more questions here, I wanted to distinguish PRP and the other cell-based therapies that we do. So PRP is platelet-rich plasma, which is what we just discussed. And then there's other cell-based therapies. Patients call them stem cell therapy, but what they are is they are cells that we derive from your own tissue. And in the clinic, we use cells that are derived from bone marrow and from your fat. And these tissues have, along with stem cells, have other cells with them that helps in the healing of your injuries. And these cells are special because not only do they have the ability to renew themselves, they also have the ability to regenerate into the tissue that's needed by your body, be that a bone tissue, a tendon tissue, or a cartilage tissue. So the specific stem cells that we are interested in is called the mesenchymal stem cells, which are naturally living within the tissues in your body. And we harvest those on the same day. And we get them ready, minimally manipulated. FDA doesn't allow for anything more than minimal manipulation, and also they don't allow us to mix it or to change it in any way. And then we do the injections in the same day. So with that, there's another question here regarding another biologic. Which is amniotic membrane. So the question is, do you like PRP more than amniotic membrane for plantar fasciosis in your clinical experience?
We do, and we can't say because of our clinical experience because we don't use these products. We characterize these as a donor product. So obviously amniotic fluid or amniotic membrane, umbilical cord blood, all these tissues that tend to be derived from time of natural childbirth, which may, by the way, contain some proteins in them. They may contain some growth factors. We know that they do not contain any live cells because these products are irradiated and sterilized. Obviously, you don't want to transmit any diseases from the donor to the patient. So the FDA does not currently permit the use of any stem cell therapies from birth tissue products. So we can safely say there are no available birth tissue products on the market that contain any living stem cells. But some of these products that do not contain live cells may contain some proteins or some growth factors. However, when you study these products in the lab and you measure the amount of growth factors, which are proteins and what are called cytokines, these are how cells talk to each other. These little molecules, the amounts of these molecules in these products is very low compared to that found in your own tissue. So you would say, Dr. Ambach, Dr. Rogers, why do you go through all the trouble of using my own blood and processing it in your lab, or my own bone marrow, or my own fat tissue? Well, versus getting somebody else's, amniotic fluid in a bottle and just injecting that product into me. And the answer is, first of all, the FDA does not permit us to use donor tissues like this. We can only use your own tissues. And two, there's really no scientific evidence that these products work. When you look at PRP from your own blood, when you look at bone marrow, or when you look at fat tissue for osteoarthritis, we have an abundance of published scientific papers that we can look at with confidence and say, this is safe and this works. When you look at these little products in these vials that come from amniotic tissue or umbilical cord, we just don't have those papers. The work has not been done. They may be safe, they may be effective, we don't know. I personally don't feel comfortable injecting somebody else's tissue into your body. It's just a personal decision as a physician. I know there are physicians who are willing to take that risk. And Dr. Ambach feels the same way. We just don't want to do that until we have those safety studies. And maybe even still not then, depending on the efficacy.
That's absolutely correct. Time flies, Dr. Rogers. We only have about 5 minutes and then we're done. But I want to answer this question with regards to how long do these therapies last? In our clinical experience, and the reason why we like to do these therapies is because they do last a long time. In our clinical experience, this is anywhere from 2 to 5 years. There was a recent publication on using PRP for back pain and injecting PRP into the discs, and their study followed these patients up to 9 years, and during that time, the patients had significant improvement in pain, significant improvement in their function. So this is not like your regular cortisone injection wherein you get 3 to 4 months good relief at best. This one is something that it's in it. You're on it for the long term. So we do want to tell you about our future events. So this Ask the Doc series is something that we plan to do every first Wednesday of the month. So our next event will be on November 4, and we are planning to go live at 12:30 to 1. So get your questions ready. We're gonna send you the topic prior to the event so that you can have your questions ready. If you have questions that are more of a personal nature, I would suggest that you call us or that you email us. I have all the information here in the live feed, and we can talk about your condition one-on-one and on a more detailed conversation. We also have a webinar next week. And this will be more detailed discussions on non-surgical treatments for osteoarthritis. And so we encourage you to join us for that webinar. We would love to stay longer and ask more questions. On the webinar as well, you have a chance to ask us questions, but we always run out of time. And that's why we started this series to just tackle questions from our audience. But if you follow us, follow San Diego Orthobiologics Medical Group in on your Facebook, or you like us, you can get this reminders from your news feed with regards to any new activity that we have out there, so that you are kept informed.
Can I just add also, we have a YouTube channel, turns out. Go to YouTube and search San Diego Orthobiologics. And I think we have about 20 videos, some of them very long, where you can learn all about the science that we're so excited about. So thank you for joining us. I think we're probably going to time out here in a moment. So thank you for joining us, and we'd love to answer your questions. Just get them to us.
So I just included all our social media outlets in the comment section. So thank you, everybody.
Thank you.